As I go around and do in-servicing, I'm often asked by clinicians how to better treat pain with utilizing our e-stim devices. Again, it's real simple. One of the most popular waveforms to use for treating pain is interferential. Most devices today have some form of interferential on them. But what most clinicians don't know about or what they can do is there's a lot of parameter changes you can do to make the treatment more effective for both acute and chronic pain. So when you look at your device, you'll go to your interferential waveform. You have to pick between channels 1 and 2 or 3 and 4 because again, true interferential needs two sets of lead wires. And then you have one of the features you want to look at is the carrier frequency option on your device. Some have just a standard set frequency of 4,000 hertz, where others have some variability to them. Some may only go from 4,000 to 5,000 hertz, where others will go all the way up to the total of 10,000 hertz, which effectively will create a different effect called the Wadinsky protocol. What that means is that we go in and we change that carrier frequency to 10,000 hertz. It allows you to bombard the sensory motor fibers and create actually a nerve block. So you go into your carrier frequency, make a quick adjustment to the highest setting you can. Preferably you want to be at 10,000 hertz because that was what the protocol used. And then just go ahead and then turn that up into a strong sensory feel. Do you feel it? Okay, when the patient gets to that strong, you want to get it to strong sensory, but you don't want it to go to motor. The one thing that everybody forgets about interferential is that it has a lot of current, or because of the type of waveform, it packs a lot of power. And you also have to remember that part of this protocol is the nerve block portion. So if the patient does go numb and does not feel the stim, what a lot of therapists want to do or clinicians want to do is they want to go keep continually turning up the device to get more power because the patient's lost in sensation. When they lose sensation with this protocol, it's just telling you it's working. So don't continue to increase the power. Just let it go and finish the treatment. Some other parts of the protocol that allow you to have a much more effective treatment that all manufacturers have some form of vector scan. They may call it something else, but what that vector scan effectively is, it's sort of like your car stereo. It's having, when we get a brand new car, we usually adjust the fade or the left and right, so we put more sound to the back if you're a rock and roll person, or we put more sound to the front if you listen to NPR. So you just don't want to listen to those voices. But again, but it allows, what the vector scan allows us to do is between channel 1 and channel 2, effectively change the amount of power going between the channels. So right now, if I go into vector scan, we'll turn it on. You normally have a choice between manual and automatic. I would prefer to use it in automatic, and then you have also the ability to change the percentage of that frequency or the power change all the way from normally 20% all the way to 100%. So what that means is that between channel 1, if I have it set at 40%, it's going to change the power or output to one channel to 40% more, come back to balanced, and then back to channel 2, add 40%, and keep varying that back and forth. It allows you to have that intersection in a much broader area, creating an ability to, again, someone who says I have more global pain versus just my elbow hurts here. The other thing that people forget to change, or another parameter set to change, is the beat low frequency. Right now, when we use the acute pain protocol, the acute pain protocol is normally a sweep of 80 to 150. That's called a beta blocker and a enkephalin. So we're blocking the sense of pain right at the synapse. The other way to do that is using a low frequency, or what they call the runner's high. And that's low, small, with methodical beating. And that runner's high gives you that release of morphine. That's one reason why I don't run. I don't want to get addicted to my own body's morphine. But if you take that and sweep those low frequencies, you'll get the low release, you'll get the endorphin release, and then you're sweeping all the way to 150, you get your enkephalin release, effectively treating your pain much better. An alternate application to vector scan is that a lot of people suffer from low back pain. And a lot of the patients will complain that they have pain running diffused all the way down into their calf. So one way is to, again, use that vector scan, turn it on automatic, and set the the percentage to 100%. We always know that we can find a dorsal root problem, usually L4, L5. We'll put one pad of channel 1 at that dorsal root problem, and then putting the second pad and creating this really long X all the way to the outside of his calf. The second channel, normally again, we have sciatic pain or what they call piriformis syndrome, where the muscle gets inflamed where the sciatic nerve comes out. We'll put the second pad of channel, we'll put one pad of channel 2 and create a very long X on the inside of his leg. And it allows that vector scan to move up and down his leg, again, subsequently treating all that referred pain down into their calf.